Last time we have discussed in the continuation of this acute leukemia. Last time we have discussed about acute leukemia in acute myeloid leukemia. So acute myeloid leukemia is a leukemic manifestations of this myeloid cell origin. So today our discussions will be concentrated on acute lymphatic leukemia, or it is called acute lymphoblastic leukemia. So in the blood cells there is a myeloid progenitor cells and lymphoid progenitor cells. So lymphoid progenitor cells are again divided into B and T subvariety. So here the leukemia is also will be discussed in the headings of B cell and T cell variety. So acute lymphoblastic leukemia, in short it is called ALL, is a malignant neoplasm of hematopoietic stem cell. So what type of cell it is? It is a hematopoietic stem cell of the lymphoid lineage and malignant formation, malignant neoplasm, and where it is in the blood, in the bone marrow, and it is circulated in the bloods. It is the commonest form of malignancy in childhood. So the acute lymphoblastic leukemia is a malignant neoplasm of hematopoietic stem cell of lymphoid lineage arising in the bone marrow and circulated in the blood. It is the commonest form of malignancy in the childhood. So there are some subvarieties which is called the precursor of B cell or B cell neoplasm or BALL, precursor T cell neoplasm of TALL, and another variety there is an NK cell leukemia. This precursor or B cell neoplasms of BALL, clonal neoplasm of immature lymphocyte committed to B cell lineage. Precursor of T cell neoplasm, clonal neoplasm of immature lymphocyte committed to T cell lineage. And another is an NK-ALL or LBL, is however very difficult to define, since these cases are positive for CD56, which is a because it is the marker of this NK cell as well as to other cells also, and resembles in immunophenotype with blastic plasmacytoid dendritic cell neoplasm, and also overlap with AML in minimal differentiation. So it is to some extent dubious. Epidemiology, the age range BALL or the scenes in the primary in the early childhood and without sex bias, that may be occurs in the male or female. With increasing age, outcome declines and infant forms are also seen. So BALL is seen primarily in the early childhood without sex bias, that may be occurs in the male or female. With increasing age, outcome declines and infant forms are also seen. TALL, peak incidence is predominantly male children, can be seen in the tissue or blood. Incidence BALL is much more common than TALL, and it is common malignancy in the children below 2 years, highest is 1 to 4 years. So the common malignancy in the children is BALL. Slight is the male preponderance. Classifications, there is two types of classifications of ALL. One is in French American British classification, FAB classification, and WHO classification, like that of a myeloid leukemia. FAB classifications in the original FAB classification, acute leukemia is diagnosed when blast cell count is greater than or equal to 30% in the bone marrow nucleated cell. But in the WHO classification, this is the cutoff point is about 20% of the blast cells. In FAB classifications, ALL including 3 categories, L1, L2 and L3. In L1, L2 and L3 by morphologically, L1 is the smaller cells and L3 is a larger cell and L2 is smaller and larger cell. Heterogeneity, L1 is an homogeneous, L3 is also homogeneous, but L2 is heterogeneous. Cytoplasm is a very thin cytoplasm in L1 and in the abundant cytoplasm in L2 and deep basophilic and vacuolated cytoplasm in L3. Nucleus, regular nuclear membrane and inconspicuous nucleoli in case of L1 and L2 is a prominent nucleoli, irregular nuclear membrane, and L3 nucleus has loose arrangement of chromatin and there is inconspicuous nucleoli. Nuclear cytoplasmic ratio is high in nuclear cytoplasmic ratio, low in NC ratio in L2 and lower in nuclear cytoplasmic ratio in L3. In WHO classification, the precursor, that is, which is initially formed 2008, but then there is a revision of 2016. There is a precursor B lymphoblastic leukemia lymphoma, precursor B lymphoblastic leukemia and lymphoma NOS, that means not otherwise specified, and precursor B lymphoblastic leukemia lymphoma with recurrent genetic abnormalities, and precursor T lymphoblastic leukemia and lymphoma, and there is an early T precursor ALL is an entity is also. In B lymphoblastic leukemia lymphoma, synonymous with B acute lymphoblastic leukemia, it is called as BALL, and WHO classifications is B lymphoblastic leukemia lymphoma not otherwise specified, and lymphoblastic leukemia lymphoma with recurrent genetic abnormalities. There are so many genetic abnormalities like T922 translocations, Q34 and Q112 translocations, and there is these are listed here. Neoplasms of the precursor cells lymphoblast committed to B cell lineage, leukemia versus lymphoma. If primarily the bone marrow and peripheral blood is involvement, defined as leukemia. If the mass lesion without bone marrow involvement, defined as a lymphoma. So it is like a milk and butter, which is when it is spilling to the blood and bone marrow, it is the leukemia. When it is in the solid part or in the then it is a lymphoma. Blast count of greater than 20% is not required for diagnosis in case of recurrent genetic abnormalities. If there is a blast count, this strictly, then not the 20% has to be maintained. If there is a genetic abnormality with these things, that it will be treated as an acute lymphoblastic leukemia. Clinical issue, epidemiology, age, it is more common malignancy in children below 20 years, highest is 1 to 4 years. Slight male preponderance and BCR-ABL associated with ALL, only type that is relatively more common in adult, and the prognosis is poor. It's 25% cases of the adult with this BCR-ABL translocations, and KMT2A-ML rearrangement type is most common leukemia in infant and may also occur in utero. Clinical presentation, bone marrow failure. Due to bone marrow failure, there is anemia, neutropenia, thrombocytopenia. There may be the leukocytosis or leukemia according to this stage, bone pain due to the proliferations of this bone marrow by the leukemic blast cells, and arthralgia, splenomegaly and lymphadenopathy common, other asymptomatic with the lymphoma variant, low stage disease. KMT2A MLL rearrangement type is this genetic abnormalities is type frequently with the CNS involvement at presentation. Laboratory find features are in peripheral blood there will be the anemia which may be severe. It is present in all patients. It is normocytic normochromic anemia generally. WBC is total WBC count may be raised, normal or low according to the procurement, according to the displacement of this normal marrow cells by the leukemic cells. Absolute neutropenia, KMT2A MLL rearrangement subtypes are usually very high WBC count, more than 1 lakhs. Platelet is thrombocytopenia and the blood film morphology, blastemia with variable morphology, maybe no blasts are found in the peripheral blood. In that cases, that may be the leukemic variety. In bone marrow examination, bone marrow is hypercellular due to proliferations of the leukemic blast. These are these leukemic blast. Normal hemopoietic elements are diminished. As a result, the blast proliferations is occurred, so the normal element gradually diminishes. The BALL with T514 translocation, Q131 and Q32 translocations is a typical lymphoblastic morphology with increased circulating eosinophils. These eosinophils are reactive in nature. Then how will be, beside the morphology, you have for the diagnosis of this acute lymphoblastic leukemia, you have to do the cytochemistry. By conventional definition, lymphoblast ALLs are negative for myeloperoxidase, which is positive in cases of this AML. In lymphoblast, PAS stain is positive in a characteristic manner, large and block-like, surrounding the nucleus and is present against a clear cytoplasmic background. PAS stain is not specific for lymphoblast. Also, many cases of ALL, about 30% cases of L1 and L2, PAS stain is negative. So, what is the solution to call a leukemia is a lymphoblastic leukemia? Then the no cytochemical stain is specific for lymphoblast. Therefore, morphological features associated with immune marker is necessary for definitive diagnosis of lymphoblastic. In ALL, in L3, cytoplasmic vacuoles are positive in cases of oil redo with cytoplasmic methyl green pyronine positivity. Then how will differentiate these B and T cell by immunomarker? In the immunophenotyping, there is an TDT, terminal desoxyribonucleic transferase, expressed by nuclei of both the P and B cell stage. In BLL or LVL, positive pan B cell marker, that is the CD19, CD10 and CD99. How will remember this thing? CD19, CD10 and CD99. And T cell marker for CD1, CD2, CD3, CD5 and CD7. So CD1 to CD7 except CD4 and CD6 are not there. So these are the T cell marker, and B cell marker is a CD99, CD10 and CD19. In cytogenetic analysis in BALL, LBL and BTALL, LBL, in BALL, LBL is unfavorable prognosis is T922 translocation, that is associated with Philadelphia chromosome, which is also cause the chronic myeloid leukemia. This type of translocation is there. The ALL is poor prognosis. There is a T411 translocation and 119 translocation. Hypoploidy less than 50% cases, there is an unfavorable prognosis. And favorable prognosis is 12 to 1 translocation and hypoploidy greater than 50% cases. In TLL or LBL, there is an 14q11 translocation, 7p1415 translocation, TCR rearrangement and TLX1 gene, 10q24 and MOIC gene deletion is 9p, loss of tumor suppressor gene CDKN2A. These are all cytogenetic analysis. We will get this in the T cell leukemia, acute lymphoblastic leukemia. Then is a treatment wise, there is an chemotherapy and the bone marrow transplantation. And chemotherapy, there is an 4 drug regimes for treating this acute lymphoblastic leukemia. There is an vincristine, prednisolone, anthracycline, which containing doxorubicin and adriamycin, asparagine. Other agents are cytosine arabinocyte and methotrexate. For CNS prophylaxis, there is cranial irradiation and the course of intrathecal methotrexate or cytosine arabinocyte. By bone marrow transplantations, when there is a chemotherapy and the will be failed, then there will be a chance of patient survivability by the bone marrow transplantation, by bone marrow stem cell transplantation, by autologous or allogenic transplantations, by stem cell bone marrow transplantations. Prognosis in the children is better prognosis than adult. Treatment in the this above treatment with the chemotherapy minus CNS prophylaxis, the patient will be survive almost 33 months. With this treatment, this chemotherapy with CNS prophylaxis, that the patient will be survive about 60 months. Adult ALL is 12 to 18 months. Patient with an limited disease, higher cure rates occur. Then is a T lymphoblastic leukemia or lymphoma. Abbreviated is T acute lymphoblastic leukemia or T lymphoblastic lymphoma. Precursor T cell neoplasm. Definition: clonal proliferation of hematopoietic stem cell with immature T cell immunophenotype. Current WHO 2016 classification combined T-ALL and T-BLL as a single biological entity. Clinical issue: the epidemiology incidence T cell ALL lymphoblastic leukemia T-ALL, 15% of all the children are ALL, 25% of the adult ALL. Age at diagnosis around about 10, half of these children is T-ALL. More common in adolescent male. T lymphoblastic lymphoma, 85% of all the lymphoblastic lymphoma. Age at diagnosis is below 10 years. Half of the children is T-LBL. Clinical presentation: T acute lymphoblastic leukemia commonly manifests as a high leukocyte count. So in cases of B, there may be normal or leukopenia, but here there is a high leukocyte count with circulating blast, often concurrent mediastinal or other tissue masses. It is important. Generally, this type of this patient present with a mediastinal mass with superior mediastinal syndrome, and immediately there will be the floodings of these blast cells in the peripheral blood and in the bone marrow. Lymphadenopathy and hepatosplenomegaly are common. Relative sparing of tri-lineage hematopoiesis in bone marrow compared to BLL. BLL generally sparing the normal hemopoietic elements in the bone marrow, but here there is generally sparing the normal hemopoietic elements. CNS involvement is more common of T lymphoblastic lymphoma. T lymphoblastic lymphoma frequently present in rapid growing mediastinal mass, pleural or pericardial effusion are present. Respiratory, as there is an mediastinal mass, there will be the superior vena cava syndrome and respiratory symptom. Bone marrow involvement at diagnosis is almost equal to 20% cases. Laboratory feature is peripheral blood examination, TLL, WBC is marked leukocytosis with blastemia. Other elements is cytopenia. TLBL, absent to minimal involvement of peripheral blood, or TLBL. Bone marrow examination in TLL, lymphoblast in the marrow aspirate shows morphological feature similar to those found in the blood. Extensive marrow involvement on core biopsy and clot section Sheets of blood cell with immature nuclear chromatin and numerous mitosis is typically seen. Contrast to B cell ALL, normal trilineage hematopoiesis is relatively preserved. TLBL bone marrow involvement is less than 20% of the cases. In cytochemistry, TALL acid phosphatase state is positive and in focal perinuclear manner. Prognostic factor in ALL in age-wise is unfavorable prognosis and is a favorable prognosis. Unfavorable prognosis below 1 year and above 10 years. Favorable prognosis 1 to 10 years. Sex, male is unfavorable prognosis as there is a testicular relapse, and female is favorable prognosis. TLC count in cases unfavorable prognosis is greater than 50,000 per cubic millimeter. Favorable prognosis is less than 50,000 per cubic millimeter. CNS disease present in the blast in the CSF is unfavorable prognosis. If there is no blast, this is favorable prognosis. Cytogenetic and molecular genetic abnormalities, hypoploidy, T922 translocation or BCR-ABL translocation, T1411 translocations or MLAF gene fusions are unfavorable prognosis. Hyperploidy and T1221 translocations are favorable prognosis. Remission after first induction, failure to remit, and early achievement of remissions. Then there is how the AML will be differ from this ALL, which is because in the peripheral blood, when you will see the peripheral blood, you have to be first differentiated from the either this blast is either what is the count of the blast. When is the blast count is more than 20% or 20% or above, it is called this acute leukemia. Then you have to be differentiate whether it is a acute myeloid leukemia or acute lymphoid leukemia. So for myeloid leukemia, you have to do this cytochemistry and markers, and for lymphoid leukemia, you have to do the cytochemistry and markers and cytogenetics. So for and in the peripheral blood for the T or B, and if it is a lymphoid malignancy, lymphoid leukemia, then you have to be differentiated whether it is a B or T side. So for this you have to do these immunophenotypings. So there is a common age in the AML is an adult between 15 to 40 years, comprises 20% of the childhood leukemia. So the AML can occur, it is also occur in the children, but its common age is 15 to 40 years. Children below 15 years is generally common in cases of ALL. Physical findings, splenomegaly, hepatomegaly, lymphadenopathy are less common in AML, but it's more prominent and marked in cases of ALL. GAM hypertrophy is present in cases of AML. GAM hypertrophy is not present in cases of ALL. Since CNS involvement is generally not present in the AML, but it is generally sometimes present is ALL. Bleeding tendency very common and less common in ALL. Laboratory findings in low to high TLC count and low to high TLC count in both sides, predominantly of the myeloblast, promyelocyte and other myeloid cell, precursor cells I will say, but in case of this ALL you will get this lymphoblast in the bone marrow and the peripheral blood. Thrombocytopenia in both the cases can be present. Diagnostic criteria, FEV classifications in myeloid leukemia is greater than in M0 to M7, here is L1 to L3. In WHO criteria for these cut-off point in cases of AML in both cases, in AML or ALL is greater than 20% cases. Cytochemical stain, myeloperoxidase, Sudan black, NSC are all positive in cases of AML, but is not positive in cases of ALL. In ALL, there is a PAS positive and acid phosphatase is positive. Specific therapy in cytosine, arabinocyte, anthracycline, durabilisin, adriamycin, and 6-thiagonine, but here is L-aspergillase beside the other drugs. Common cytogenetic abnormalities is T1513 translocation, M4 is in 16 translocations, and in cases of BALL and TLL, there is a translocation of 921 is the worst prognosis, and there is an for TLL 14q11 11 translocation. Response of therapy, remission rate is low, duration of remission is shorter, remission is very good, the remission, initial remission is good, and the remission rate is very high and duration of remission is prolonged. Median survival is 12 to 18 months, but in cases of the children there is a 33-month translocation without CNS prophylaxis, with CNS prophylaxis 60 months, and in cases of adult 12 to 18 months. So, to summarize this whole ALL, that like acute leukemia is consisting of these two parts, acute myeloid leukemia and is an acute lymphoblastic leukemia. So lymphoblastic leukemia again is the two part, one is an B cell and one is the T cell. If it is a B cell, there are some clinical feature, T cell has also the. So B and T cell you have to be differentiated by immunophenotyping or immunological marker. And beside this there is a genetic aberration, cytogenetic analysis, you will be decided which is a B cell and T cells. So this is this I will be in short discussions of this acute lymphoblastic leukemia. So read these books in your read your books and textbook, and you will get this more information. If there are any difficulties, contact me and for further classification.